This talk is about intervention functions and policy categories. So we're now moving from the first steps from which were identifying the evidence practice gap, understanding the behavior, and defining the behavior in behavioral terms, which is the part that you all are going to do tomorrow in this small group. You're going to take those first 3 steps and try to identify what are the barriers and come up with a behavioral diagnosis. What we're going to look at now is once you have that behavioral diagnosis, what do you do with that information? So hopefully this can kind of help you see where we're going over the next day or so. So in this stage of identifying intervention options, before we get to the final thing, which is going to be identifying the content and implementation options, we're going to identify intervention functions and policy categories. So there are really 8 steps here, as you can see. And the first step is involving the COMBI model for understanding behavior, identifying what needs to change. We're going to go deeper into the behavior change wheel, which is what you've already seen. And then ultimately, we'll be applying something called the behavior change taxonomy to identify what specific behavior change techniques can be used to deliver these intervention functions. So what are interventions? Interventions are activities that are designed to change behaviors. We've been specific about what those candidate behaviors are. We're going to be specific tomorrow about what the barriers and enablers of those behaviors are. But these interventions are listed here on the outside of the wheel. And those include education, persuasion, incentivization, coercion, training, enablement, modeling, environmental restructuring, and restrictions. I'm going to define these carefully in the next slide and then try to give some examples of them. But just to get used to the names of them and where they lie. And recall that this wheel is a wheel that can spin. So we're going to be trying to match up certain categories of a behavioral diagnosis, problems of capability, whether physical or psychological, motivation, whether automatic or reflective, and opportunity, whether physical or social. These are going to map to these individual intervention functions. Sometimes you'll find that intervention function can have multiple impacts. It can impact multiple underlying behaviors. But this is just a way of sort of thinking about the relationship. And one slight distinction of terminology is you'll notice that for the most part we'll be talking about intervention functions. Intervention functions are ideas based on the general mechanism by which they work. So education works by transferring knowledge, addressing knowledge barriers. There are other ways that it can work as well. Education can sometimes help to prompt memory, decision processes that are important for achieving a certain type of behavior. And there are other aspects as well that can sometimes occur. So what are these intervention functions? We'll now kind of go around the wheel. So you can see, first of all, education, as we mentioned, is designed to increase knowledge or understanding. Persuasion is like education, but it adds an emotional kind of content to it. We kind of stop just being, with education, maybe you're more just factual. With persuasion, you're thinking about what particular things can you say to convince someone to do the behavior that you're trying to change. So that may induce positive feelings, it may induce negative feelings, but ultimately it's intended to stimulate action or behavior change. Next is incentivization. This is creating an expectation of a reward. A financial reward is the most common form of an incentive, but there are other kinds of incentives as well, to the extent that people are motivated by recognition by their peers. So this could be like a plaque on a wall saying that you're the employee of the month, or honoring you for your service to the School of Medicine. There might also be an incentive that would be a parking space that you as the employee of the month could use just for that month. So these are different types of incentives, monetary and non-monetary. Next is coercion. So this is creating an expectation of punishment or cost. So an example of that might be a a fine or a penalty or a castigation for not following the rules. Next is training. So training is transfer of a physical skill or capability. So I think it's very easy to think about this in terms of sport. To make a better sport player, you can do training. So this is also often physical. In terms of a health setting, it may be training someone to do an actual procedure, like in the case of safe male circumcision, doing it correctly and properly. Or it could also be some medical things, a physical examination skill, for example. Next is enablement. Enablement is a little bit of an overlapping category, and it can be thought of generally. In some ways, it captures other types of interventions that are less specifically defined. And that's defined as increasing the means or reducing the barriers to increase capability. And it's specifically said that this is beyond education or environmental restructuring, which I'll come to in a moment. By increasing capability or opportunity, you can help enable a certain behavior. So this could be a prompt or a reminder, perhaps. It could be some form of social support, maybe to enable things. Maybe it's offering services more quickly or in a privileged basis for certain types of populations so they don't need to wait a long time to get access to care. Next is modeling. So modeling is providing an example for people to aspire to or emulate. There's a couple of types of modeling. One is expert modeling, and that's often used to augment training. You're learning to do a behavior, let's just say it's hitting a tennis ball, and you can see a coach show you how to do that. You can watch videos to sort of see how that works. Those would be examples of modeling. There's also a form of modeling which is not expert, but it almost comes through as a form of social support. So an example of that might be patient support groups, meeting with somebody who's already been through, done the same behavior for the same condition in the past. Maybe they've struggled with it in ways that you can identify with. They're not an expert, but they struggled through, they got through it, and they're modeling that behavior to say, even though you may find this difficult, even though you may not think you're able to do it, I'm trying to serve as a model for you so you can realize the benefits of doing that behavior. The next is environmental restructuring. So this is changing the physical or social context. This is very common with clinic-based behaviors that flow through a clinic may not be designed to deliver a certain type of intervention. Maybe by rearranging items, you could improve the quality of resuscitation because you observed that in a critical moment of resuscitation, a key element was not available, perhaps fluids to administer, or in the case of a trauma, there might be a certain ultrasound that you would need to identify or manage a patient. It can also be restructuring the social context. So a few years ago, we were working in a rural health center and looking at screening behaviors for identifying patients who were possible TB patients and getting them through the full evaluation. And part of that evaluation was getting HIV counseling and testing done. There were a number of barriers to getting that done, but one that the in-charge had identified was the place that HIV testing had been identified required people to go out of a clinic room and go into another one, which was stigmatizing. So he restructured the way services were provided so that all providers could do HIV testing, and it could be done in another location. So that's, in a way, restructuring the social context as well as the physical context to enable a behavior to happen. And then finally, there are restrictions. So restrictions is using rules to reduce the opportunity to engage in the behavior or to increase the behavior by reducing opportunity to engage in competing behaviors. So I think one of the best ways to think about this is in terms of maybe traffic signs or traffic barriers to keep people to travel a certain way. You don't want people to merge and interrupt the flow of traffic, so you create barriers to prevent that. So there'd be examples of restrictions. Another example might be in order to prevent teenage smoking, requiring places that sell cigarettes not to display them openly, but to place them below the counter or someplace where you specifically have to ask for them. So that's another example of a restriction that may be able to induce a behavior change. So we'll go through some more examples, but does that make sense? Can anybody think of an intervention function that we haven't captured with these 9 intervention functions? So as I go forward, you can maybe think about the particular problems that you're looking at, maybe interventions you've designed in the past, and think about which of these categories they fit in as I go forward talking. So remember, I distinguish between interventions and intervention functions. One reason for that is that an intervention can have multiple functions. So this is a traffic sign from the New York Department of Transportation. And what you see here is, at its core, this is a public health message, is this image, this kind of powerful image that shows a skull and a face, and then you have these messages. Hit at 40 miles per hour, there's a 70% chance I'll die. Hit at 30 miles per hour, there's an 80% chance that I'll live. That's why it's speed limit 30. So this intervention has the functions of both education, changing people's knowledge about why this speed limit exists. It's actually something I never thought about, why 30 and not 40. So I felt educated by this. But there's also emotional content embedded here, right? In terms of what's said, in terms of the probabilities. Yeah, and there can be some ethical implications of these things, but just to think about, analytically, sort of what's going on here. And also, I think another thing I'll point out is sort of the way they display these percentages. Here they're showing the gap, and here they're showing sort of the benefit. Okay, good. So these intervention functions I mentioned do map to the behavioral diagnosis, so these COMBI categories. And they do so in a way that's relatively complex. As you can see here, this grid is sort of showing you which particular intervention functions have been linked to particular categories. So I'll go through this. I mean, I think it's the kind of thing that does require some study and some thinking. And as you go through it, you may start to see some relationships between different categories. I'll try to draw that out to some degree, and some differences between categories. First, we're talking about capabilities, so kind of physical and psychological capability. And I think it does help to sort of start with the diagnosis and move to the intervention. So among the physical capabilities, the things that you can do to address are training and then enablement, things that you can do. So maybe training is learning the skill, and enablement potentially would be the coaching to kind of help that happen. Next is psychological capability. So clearly lack of knowledge can be addressed through education. Also putting that knowledge into practice may be addressed by training. So sometimes simulations and things like that can help promote the impact of education. Also having a chance to put it into practice is another aspect, and that can be thought of as a notion of training. And then enablement can enhance psychological capability, often through prompts or cues to kind of promote your understanding or your knowledge, helping you remember to do things at certain times. For example, take your medicine. That might be the advantage of an enablement. Next are the opportunity categories. So physical opportunity can be addressed through training to kind of know where physical resources are available. In a negative sense, you can also sort of restrict the physical opportunity, again, the road example that I gave, to help kind of promote the behavior that you want to. You can also restructure the environment to help make physical opportunity better. So this might be, again, this example of kind of reorganizing the clinic to make it easier for these things to happen. And then again, enablement would be things beyond environmental restructuring to kind of enhance physical opportunity. I think one thing that we see a lot is just the lack of time sometimes to do certain behaviors. And so task shifting or offering support or other engineering steps to maybe decrease the barriers. Certainly electronic means are often thought to be a way of enabling physical opportunity to do less time. Unfortunately, I think in practice they tend to make less time to deliver them. But just an idea of the way interventions are sometimes framed. Next is social opportunity. There are certain societal restrictions. If you take a country like Saudi Arabia, the social opportunity of women to do certain behaviors like drive a vehicle are sort of restricted in a society. This isn't a positive health thing, but just so you can think about how some things are delivered. Environmental restructuring to address social opportunity. I think I gave the example of the clinic intervention that was done to promote HIV testing. And we've talked a little bit about modeling and enabling how those can help act on social influences to make people be more comfortable in pursuing certain types of behaviors. Finally, motivation. What you can see about motivation is that automatic motivation, which are these deep-held feelings of emotions, for example, those can be addressed by almost all of these behavior change. The only things, interventions, the only thing that don't address it directly are restrictions and education. And reflective motivation, which includes elements such as social and professional identity, beliefs about one's capabilities, beliefs about the consequences of certain behaviors, goals and intentions, and just one's general kind of optimism or view of the world. All these are things that can be addressed or promoted by education, persuasion, incentivization, or coercion. A couple of things to comment on is that incentivization, coercion, and restriction are all ways of well, I guess you can sort of think of incentivization and coercion as flip sides of one another. And restriction and coercion are not very commonly used in public health interventions because often they're not acceptable either to users or thought to be ethically acceptable. So you may find that those can be, those are either feasible or acceptable in only a small number of cases. So anyway, I think as you try, if you want to try to learn about this, I think it does help to kind of look at them in different ways, go across the rows, go down the columns, and think about how they're related to each of the categories. So I think the way it helps to think about these things is to start with your behavioral diagnosis and then go across and think what the definition is of each of these intervention functions and try to see if it will apply in your context. So how do you go about doing that? You do that by applying what we call the APPEASE criteria. So APPEASE is an acronym, of course, and the elements of that acronym are acceptability, practicability, effectiveness and cost effectiveness, affordability, safety, and equity. So a little bit like we did before in terms of thinking of which target behaviors we were going to include in our intervention or we would prioritize in order to achieve the target behavior change. Here we're also getting the opportunity to bring in our knowledge of the system, our common sense, even the opportunity to look in the literature and see what is known about specific intervention functions and decide whether these are a good idea to apply in these circumstances. So acceptability is the appropriateness of an intervention as assessed by relevant stakeholders. So these could be the general public, these could be professionals, or people with a political or policy role to kind of understand. And these, of course, can vary based on your local context and your sort of the values and overall ethics of your health system and how you look at that particular intervention. Practicality or practicability is whether a particular intervention is deliverable to the target population within the available means. So again, this is a little bit of a qualitative judgment sometimes, because you also have to think about what are the competing interventions that you could deliver for this particular target behavior or other target behaviors. Effectiveness is what's the effect size of the intervention in relation to the objectives in a real-world context, as distinct from efficacy, which would be in a kind of controlled research area context. And then cost effectiveness is, as you know, the ratio of the effect or the change in the effect that you could achieve relative to the cost in your population. Sometimes cost effectiveness studies are done embedded within efficacy studies, so you may have to think more broadly about whether those deliverables are likely to hold in your setting. Affordability is deliverable to the target population within the available budget. Safety is thinking partially about some of those spillover effects. Are there sort of unwanted positive or negative consequences of delivering this intervention? Some of these persuasive messages frightening people, they may be effective at getting people to come, but what are the side effects of that? Maybe they have a long-term bad feeling towards the health system, or maybe they're less likely to stay in care. So you do have to kind of think more broadly about which of these functions make sense to use. And then equity, does the intervention reduce or increase disparities in a standard of living, well-being, or health between different sectors of society? So again, you would use common sense and potentially the literature to help make these decisions. And sometimes as you develop an intervention, in fact, probably always, it's good to engage your stakeholders at this level and say, these are the things that we're considering. Do people think that these things will work? So we did that actually. Achilles did that earlier this week with a project that he's doing related to pediatric TB and getting input from other pediatric TB stakeholders to see which of the intervention functions that we identified might potentially be workable in this setting. It was very helpful. Really changed the way we thought about certain of the intervention functions, or at least that Achilles did. Let me just say something about COMBI. How was COMBI developed? As Aditya talked before, it was developed from these 33 theories of behavior change, and they got together social scientists from a lot of different backgrounds and tried to find what were the core domains that were present. And they did something similar for intervention functions in order to map them to meet these particular behavioral diagnoses. In some ways, COMBI is a simplification of another theory, which is called the theory domains framework, which includes a few more categories. I think after you've engaged with this a bit, it would be worth looking at that, and we can share some resources with you about it. But what the theory domains framework does is that it breaks down some of these categories into broader categories. Some of them stay the same. Physical capability is still just really about skills. Social opportunity is still really just about social influences. But it turns out that reflective motivation and automatic motivation have multiple kind of categories. And some of the language that I was using relates to that theory domains framework. I think there's probably more to it than that, and it probably just reflects the limitations of our understanding about neuroscience that underlies motivation. But I think there are theories out there about how that works, and hopefully as we learn more about the mechanisms of how this works, maybe we can answer that question better. All right, so I'm going to give a few examples. So this is a behavior that we want to try to improve, which is getting people to boil water that they collect from unknown sources where it's not clean before they drink it. So in this particular analysis, what was the target behavior that needed to happen? What needs to happen for the target behavior to be able to occur? So people have to be able to boil water before drinking it. So they have to have a fire and a pot and some fuel to be able to do that. And the assessment of this group was that no change was needed in order to make this happen. Next was psychological capability, knowing to boil the water before drinking, knowing how to establish reminders, routines, and habits to boil water before drinking, and having the advanced planning skills to ensure a supply of cooled, boiled water so that you don't become thirsty or need water at a point when none's available. And these were identified as areas where a lot of change was needed. Next was physical opportunity, having a water container and a stove in order to be able to do that. So it was thought, again, that there was no change that was needed. Next is acceptability and expectations of boiling water before drinking. Many people maybe think that it's not necessary to do this. This is just a delay or a waste of time or extra work, an extra cost to get the fuel to boil the water. And they thought that some change was needed. Reflective motivation was intending to and prioritizing boiling water before drinking. And change was needed in this. People had to believe and set goals and have intentions to do that in order to make that happen. And then automatic motivation was establishing reminders and routines and habits to boil water. And that also needed changing. And so ultimately, they identified these categories: psychological capability, social opportunity, reflective and automatic motivation are needed in order for the target change of boiling water before drinking to occur. So then they moved forward to try to see which of the functions were available. And because so many of the categories were affected, as you go across, you can see that quickly we find an intervention function that maps to all of the different behaviors. And some of them, like persuasion, will impact both forms of motivation. Training can act on psychological capability, and also, in this case, act on automatic motivation, which were two relevant categories. So you can see how this works as you go across. And by doing that, you can start to think about which of these categories were appropriate. And so as they did that, they then went through the appease categories. And they felt that education was affordable, acceptable, practical, and likely to have an impact in this context, as was persuasion. Incentivization, while there's strong rationale to believe that that could have big impacts on automatic and reflective motivation, not really feasible to incentivize people every time they drink or boil water. Coercion, as I mentioned, this is very rarely acceptable in terms of public health interventions. I think coercion is only generally acceptable when there's harm to another party involved. So there might be situations where that's acceptable, but not for most public health interventions. Training, like education, was thought to not be so difficult. A restriction was not really practical or relevant in this particular scenario. You can't restrict people's access to water. It's everywhere. Environmental restructuring. Potentially setting things up so it's easy to boil water and kind of carry out these behaviors and store water. Modeling, so maybe getting members of the community to show how this is done and disseminate that information would be useful. And enablement, potentially providing pots or instructions in sort of how to do this adequately, right? I mean, you have to let the water boil for a certain period of time before you know that anything that might be in it would be sterilized. So let's do another example. This is delivering pediatric services in Kenya. So this is a group that's working within KEMRI, and they published a cluster randomized trial of this complex intervention that was shown to be effective in improving the delivery of pediatric services in hospitals, in multiple hospitals in Kenya. But they wanted to understand, they described sort of how they designed this using Combi. So what needs to happen in order for the target behavior to occur? The target behavior, what needs to happen is that we need to have physical capability. That is, leaders need to work with frontline staff to improve their knowledge, skills, and practices. And is there a need for change? Yes, those expected to perform this role are often poorly prepared or equipped for it. Develop information systems, feedback mechanisms, and discussion fora to improve psychological capability. There's limited information about established guidelines on delivery of pediatric services in health facilities. It's difficult to routinely monitor these practices and outcomes to try to see if these are done in accordance with the guidelines that have been established. In terms of physical opportunity, there's a need to work with managers to mobilize resources and improve the organization of services. They lack supplies and equipment, which is the main physical opportunity barrier, and they're often geographically isolated from supply services, and so they need to be able to do things to help address that. Social opportunity, provide health workers with understanding and support. The system provides little emotional support and they are professionally isolated. So these providers are in remote areas, they're overworked, they feel underappreciated, and these social influences are acting as a behavior for them following through and feeling good about the activities that they're doing. Reflective motivation, shaping an appropriate role for key personnel and promoting identification and ownership of the role. So those expected are not have the responsibility, but they've not yet taken ownership of this role. And you'll have to forgive me, I'm going to have to prompt my memory about automatic motivation because it's not showing on the slide. So automatic motivation actually wasn't a category that kind of came out in this particular analysis. So we've identified almost all the categories as being a barrier. What are the intervention functions that kind of address these particular ones? So they've gone through the appease criteria and thought about which ones meet all those criteria and are worth trying to intervene. And actually, they're looking back at how they designed this intervention function. Sometimes this is useful, even as a retrospective exercise, to see what generalizable knowledge can come out of what you've already done. Just to say it can work in different directions. And so what they identified was that training was an intervention function to kind of help do this. So providing not only clinical training of trainers, but also management training to these individuals who are empowered. So these are often physicians working as kind of medical directors in these health facilities. Psychological capability, certainly education and enablement were mechanisms that they use to increase psychological capability, making available kind of experts that they could get in touch with to talk about particular management or clinical problems that they were dealing with through a community as a practice model. Physical opportunity, so restructuring the physical environment to make sure that the things were available, oxygen, fluids, antibiotics to deliver these guideline-based care. Again, enablement could be things like just making these things more accessible so you don't have to go to the store to obtain things. They're right there on the ward and they're regularly supplied. In terms of social opportunity, modeling good behavior, so showing, highlighting the good performance that may be happening in certain facilities to other facilities, giving examples of how they solved problems that they could then be solved in that facility. It's sort of an example of enablement. And in terms of reflective motivation and shaping this appropriate role for key personnel and promoting identification and ownership of that role, again, education, persuasion, encouragement that they're doing a good job and that they can solve these problems, that they really have the capabilities of doing these things, and that their role in the facility, sometimes a barrier was that people would say, that's not my job. So one of the things that was effective was getting a notion of shared responsibility, people identifying that they could change things, and that they could setting goals and intentions to kind of achieve those things. So this is quite a complex intervention. It might have been very challenging to do this prospectively, but retrospectively, by doing that, it helps them think about how they can take this intervention potentially to scale, what aspects are adaptable to other settings. Okay, I think I've kind of gone through this. You can see a few other things that they did in terms of standardized indicators, measurement, feedback reports. These are kind of some of the specific interventions. Here's a different way of looking at that. This is from this same paper. Is kind of, we were talking earlier about mapping the processes of care and developing a logic model. So you saw a general logic model earlier today that talked about environmental and behavioral factors at multiple levels within the health system. What they've done now is overlaid COMBI on top of this and sort of started to think, well, this inner square here is sort of mid-level management. And you can see the different types of interventions in terms of capability, opportunity, and motivation that address mid-level management. And then at a broader level, there are elements that target senior management. So those are the ones that are in blue. Not quite as many of those, and some of the other ones is the ones that targeting frontline health workers. But these also, by creating a supportive hospital environment, for example, and engaging with performance review, that may be an important responsibility for senior management. And then there's the sort of overall system context. So just an example of how you can convey this information to others and talk about how you actually achieve something. So I'm going to go through steps 6, 7, and 8. We're not going to go into quite as much detail as we did in the intervention functions for a couple of reasons. For some of these, honestly, the behavior change wheel materials are sort of less developed. So I'm going to give you kind of a concept of what the value of these is. And we can talk more informally if if you have individual questions about these aspects. And I think another aspect is, particularly when we get to the behavior change techniques, which will be the next lecture after this, there are so many of them, it's not really feasible to get engaged with them in a lecture format. So I'm more going to introduce you to the concept of them, and then we can play around with them some in the small groups as we go along. So intervention functions, as we talked about, is the process of mapping interventions, which can be multimodal and they can have multiple effects, to this behavioral diagnosis. And I think some of that came out, at least in our group this morning, in terms of how that might work, because as you're talking about what the barriers are, you're already thinking about how you could address those and reverse them. There's another category which is called policy categories. I think for some of you this will be very familiar because you're working at the national level or you're working at the administrative level of a clinic or a clinic network. But often I think researchers in our position may not be thinking about policy categories. They're more thinking about the local interventions because they're very close to the providers or the patients or whoever the target actors are for the specified behavior. But policy categories can be thought of as a kind of lever, a way of taking the intervention function that you're delivering and charging it, being able to scale it to a larger level so that those impacts can be realized. So I'll talk about that as we go along. So we talked over the last few days about how the behavior change wheel was derived. I think I said 33 theories and then perhaps 19 frameworks. And to do that, they got to the 9 intervention functions that we encountered yesterday. But in addition, there were these 7 policy categories. And this process of emerging through those allowed those experts to identify which policy categories could help leverage different intervention functions. So again, the behavior change wheel, we start with behavior. The behavioral diagnosis is at the core. And again, this kind of goes back to, I think, a core principle of intervention design, that if you don't get the right target, you won't get the right intervention. So you don't want to shoot from the hip. You want to take aim and make sure that your intervention is well targeted, because sometimes if you don't do that, you won't get any effect, or sometimes you may get the wrong effect of what you want to get. As you saw, the intervention functions are in the red level, and in this gray level all the way on the outside of the policy categories. So I'll start up here, environmental and social planning. And again, we'll give definitions in the next slide. Communications and marketing, legislation, service provision, regulation, fiscal measures, and guidelines. And this wheel is meant to rotate. So it's not necessary that the relationships between different levels of the wheel are constant or that there are relationships between every level. But it gives you a concept that as you move outward, you have a different level, you're acting in a different level of the complex system that you're working in to achieve the overall goals of specific behaviors. So so policies, the definition really is decisions made by authorities concerning interventions. And why would we want to use these? I mean, there's a couple of reasons why engaging with policymakers may be helpful to you. For one thing is that it may cause you to be more careful about the claims that you're making. If you're going to really scale them to national level, if you're going to go before a public entity and make a statement that something is important, you really want to think carefully beyond just your own context. And that may cause you to be more careful or more rigorous about how you define your evidence or how you collect your evidence. And then the other aspect is that, as I kind of talked about, you don't want to just replicate your interventions in different settings. Ideally, you'd like to take them to scale because going back to that evaluation thinking, which I don't think we're going to get to today, but that we talked about a couple days ago, is that it's not just the effectiveness of your intervention, it's the reach and all the other aspects of that. How can it be adopted, implemented, and maintained? So here are some little cartoons to give you a sense and some examples. I may stop for a moment and even ask you to give examples from your own work. So as you're listening, think about if any of these policy categories trigger a memory of something that you've used either within your program or again at the national level through the government sector, or another area where this might come out is through professional or expert societies. So environmental social planning is designing or controlling the physical or social environment. So an example of this might be, I think, particularly with urban planning. So we've seen in the last few years the Kampala City Council has taken a more active role to planning certain aspects of life in the city, whether it's the way transport happens to some degree, or the way vendors are sort of lining the street. So that's an aspect of environmental and social planning that might have safety implications or other types of implications for traffic congestion and things like that. Next is communications and marketing. And this can be the print, electronic, telephonic, or broadcast media. I think, of course, we'd have to include social media in today's day and age. This is ways of getting networked with other people and has important implications for particularly issues of social identity. You know, so much of how we think of ourselves is from what the media puts in front of us as a mirror. So that can be a very powerful instrument, of course, in terms of addressing certain types of perceptions and certain types of identity issues, social influences, et cetera. Next is legislation, and this will have some things in common with a couple other characteristics that we'll come to in a minute, fiscal measures and regulation. So this is making and changing laws, passing laws so that if people follow certain behaviors, there would presumably be penalties, right? So this would get into the concepts, the intervention functions of coercion, perhaps, I think it's really about coercion mainly. Next is service provision. This is a pretty broad concept because services can be provided in so many contexts. And I think a lot of the innovations that you see now coming about are thinking about how services can be provided in ways that are more patient-centered. But often those models have to be tested at larger levels, and so policies or recommendations from experts may be important in terms of helping deliver that service or changing models of service and make them available. Regulation is establishing rules or principles of behavior or practice. So professional societies may do that in terms of the way we practice, in terms of what's required. There may also be things that the government requires that maybe don't rise to the level of crimes if we violate those, but there may be penalties for businesses if they don't follow certain regulatory patterns. And certainly in terms of healthcare, we see that a lot in our setting now that there are regulations about how information is exchanged with patients, some things about quality, some things about patient rights as they're being treated and evaluated. Next is fiscal measures. So fiscal measures is kind of more of an incentivization, could also be kind of coercion, depending on how those fiscal measures are structured. So those could be taxes on the individual, they could be tax credits, they could be potentially tariffs on the way goods are imported or sold. So this really gets to the concept of restriction, especially, as does regulation. In terms of, we can think a lot in terms of the way drugs are brought into the country or the way their quality is verified. And then finally, we have guidelines. So this is creating documents that recommend or mandate practice. And this includes all changes to service provision. So if a new national policy comes out that says that household contact investigation for TB should take place, that may change sort of the way services are provided compared to the old way of providing them, which would have been in health centers. So yeah, so this is this large blue grid. I don't know how helpful it is to sort of go over it in a lecture format, but it is, while it's intimidating, it's fun to kind of look at it. And as you look at it, I encourage you to go sort of across the rows and down as well, because you can kind of see some particular patterns. So communication and marketing, for example, really gets at these intervention functions of education, persuasion, incentivization, and coercion, and also has an aspect of modeling. So if you think about communication and marketing, whether these are radio ads or television ads or things you might see on the internet, I think these things kind of start to become familiar in terms of the way marketers deliver their information. Guidelines, as you can see, can affect pretty much all aspects of intervention functions. The only ones they don't touch is modeling, and I guess that's because guidelines kind of come from authorities, and modeling is really about having peers giving you these messages. I'm trying to think of other things. Just drawing the point that regulation and legislation are really very closely related. They hit all the same intervention functions. It's just a matter of whether we're talking about penalties or criminal offense or different types of incentives or coercion. And then environmental and social planning is actually relatively restrictive, right? It's only sort of addressing environmental restructuring or enablement. Service provision, similarly, is a pretty broad category that touches almost everything. I think compared to the mapping between intervention functions and the behavioral diagnoses categories, the COMBI categories, there's a lot more blue here. And I think it reflects just the creativity that comes with policy. You know, if you're in charge of things, you can try a lot of different aspects, assuming that there's a mechanism by which it can take place. So here's an example, Agre's example basically, which is what behavioral change techniques, so this is going to be the next direction we're going to go to after the policy categories, getting very, very specific about what we're doing. And what you're seeing here is a variety of different techniques to actually change behavior. And they act through different intervention functions. So the blue ones here, placing cigarettes under the counter and doing a smoking ban, are sort of environmental restructuring. I think there's a little bit of an aspect of restriction as well, I would say, in terms of where things are placed. And those map to the legislation category. So in order to make those happen, you know, you could just issue this as a guideline, but it might not work that well because perhaps the people selling the cigarettes want them to be as visible as possible. So you really need probably more the stick than the carrot to make these things happen. On the other hand, there's a variety of enablement functions that can happen. So facilitating relapse prevention and coping by providing support groups, for example. Advising on stop smoking medication so that people can control these automatic motivation aspects. Advising on changing routines to set up new habits so you don't hang around smokers or engage in behaviors that might be associated with smoking. And then seek a commitment. This kind of gets at social identity, beliefs about capabilities, and the enablement function. And all these things can be achieved by providing a service. Rather than just leaving people on their own to figure these things out, you make people aware of the resources that you can provide. So again, this idea of a lever to kind of connect things. So selecting policy categories similar to intervention functions requires judgment. So you're again going to want to apply these APEAS criteria of acceptability, practicality, effectiveness and cost effectiveness, affordability, safety, and equity in going through that. And so let me give an example of how this works. So this is a hand hygiene and hospital staff intervention. So nurses and doctors were identified as cleaning hands in identified situations. Infection control nurses, these are intervention functions, were conducting audits and feeding back results. And staff were responsible for distributing alcohol hand rub, ensuring that dispensers contain alcohol hand rub. So these intervention functions and behavioral change techniques were addressing incentivization and enablement activities that address reflective motivation, automatic motivation, and physical opportunity barriers. And so the question then is, what policy categories might help us leverage incentivization and enablement in order to achieve that? This is kind of just a general worksheet. I don't think we'll be, I guess we'll have an opportunity to kind of go through this a little bit this afternoon. But these different categories are kind of nicely laid out for education, so you can start to think for your particular behavior that you're trying to change, which of these would be relevant using those appease criteria, and help you know how to leverage those.